Hello friends, welcome to another interesting video. A patient once asked me, Doctor, if my knee cartilage is already worn out, won't exercise finish it off? That question sounds very logical. After all, if a car tire is worn, driving more will wear it further. But your knee is not a tire. It is a living joint surrounded by muscles, bones, ligaments, tissues that respond to movement. And here is the surprising part. In many people with knee arthritis, avoiding movement may create more problems than carefully chosen exercise. So in this video, I am going to show you what the research actually says about exercise and cartilage, why pain does not always mean damage, and how to know whether you are helping your knee or simply doing too much too soon. Osteoarthritis or arthritis or mutu thaimanam in Tamil is not just wear and tear. Osteoarthritis is not simply cartilage being rubbed away. It is a disease of the whole joint involving cartilage, the bone beneath it, the joint lining, the ligaments, the capsule, the meniscus, and the muscles around the knee. A major review in the Lancet describes osteoarthritis as an active and dynamic process involving mechanical, inflammatory, and metabolic factors. It is not merely a passive wear and tear condition. A previous injury, the alignment of the joints, age, genetics, obesity, inflammation, and muscle weakness may also contribute. Different patients can therefore have different combinations of the same disease. Normal movement is not automatically the enemy, but the dose of movement still matters. Too much, too quickly, and without preparation may irritate the knee. Too little movement may weaken the entire person. The goal is not zero load, the goal is the right load. I told Doraisamy exercise can be a path of treatment and the dose matters. He leaned a little closer and asked very seriously, Doctor, should I do it before food or after food? His wife Kamala, who was sitting beside him, turned towards him and whispered, Enanga, first start doing it, we can decide before food or after food later. That is the problem. We often start worrying about the perfect timing before we have even started moving around. Does exercise damage the cartilage? Researchers have examined this question directly. A systematic review by Bricca and colleagues included 9 randomized trials involving 702 participants who either had knee osteoarthritis or were at increased risk of developing it. The studies used MRI to examine cartilage thickness, volume, defects, and composition. The conclusion was very careful. The knee joint loading exercise seemed not to harm articular cartilage, but the authors also clearly stated that the overall quality of evidence was low. The studies were relatively small and exercise programs differed. Adherence was sometimes poor and some interventions were outside what the authors considered an ideal therapeutic loading range. So the correct message is not every exercise is safe for every knee. The correct message is appropriately selected and progressively dosed therapeutic exercises does not appear to accelerate cartilage damage. A gradual walking or strengthening program is not the same as suddenly doubling your activity or attempting a marathon without preparation. Exercise can be a part of the treatment, but dose matters. What is the capacity versus demand? Here is the simplest way to understand the knee symptoms. On one side is the demand, which means what you ask the knee to do, such as walking, climbing stairs, squatting, lifting, standing, or long periods of running. On the other side is the capacity, which means what the knee and the person can tolerate today. The capacity depends on the muscle, strength, swelling, balance, previous injuries, sleep, recovery, body weight, confidence, or previous training. When demand suddenly exceeds the current capacity, pain or swelling may increase. That does not automatically mean that more cartilage has been destroyed. It may simply mean the activity dose exceeded the knee's present tolerance. Yes, so a good rehabilitation therefore does two things. One, it temporarily reduces the excessive demand and gradually increases the capacity. I explained this to Doraisamy. He moved a little closer and said proudly, Doctor, I have completely stopped squatting to protect my knee. I asked him, then how are you sitting on the toilet? He paused for a moment and replied with complete confidence, that squat is compulsory, doctor. Gym squat is optional. Your knee does not know whether the squat happened in the gym, kitchen, or bathroom. It only knows how much load was used, how deep you went, how controlled the movement was, whether the knee was prepared. A squat is not automatically dangerous. One person may begin with sit to stand from high chair, while another may do a supported partial squat. The movement should be adapted. It should not be blindly forced, and it should not be automatically forbidden. Why complete rest can backfire? When someone stops moving because of the pain or fear, a downward cycle can begin. Less movement leads to weaker muscles, walking and stairs become harder, Fitness falls, weight may increase, confidence decreases, the person then moves even less. The danger is not only what arthritis does to the knee, it is what prolonged inactivity can do to the whole person. Bennell and Hinman note that people with knee arthritis commonly experience pain, weakness, stiffness, instability, and reduced physical function. These problems can ultimately contribute to loss of independence and poor quality of life. They also emphasize that exercise is an important part of osteoarthritis management. Short-term reduction of activity may sometimes be useful during a flare-up, but prolonged complete inactivity is rarely the long-term answer. What type of exercise helps? The evidence support both strengthening and aerobic exercises. The strengthening exercises may include sit to stand, supported squats, step-ups, knee extension exercises, hamstring strengthening, calf raises, and hip strengthening. Stronger muscles do not replace the cartilage, but they can improve control and make everyday activities easier. Aerobic exercises may include walking, stationary cycling, swimming, aquatic exercises, or short walking intervals. A person who currently tolerates 5 minutes does not need to begin with 30 minutes. They may start with 5 minutes, rest briefly, and repeat. The best program is not the most impressive program. It is a program that patient can perform consistently, progress gradually. Bennell and Hillman report that strengthening exercises can improve the strength, pain, function, and quality of life, while aerobic exercise can reduce the pain and improve function and cardiorespiratory capacity. They recommend an individualized approach based on patient symptoms, mobility, and needs. Adherence also matters. The same review notes that adherence is a major predictor of long-term outcome, and the benefits tend to decline when exercise is stopped. Body weight and knee arthritis. For patients who are overweight or obese, exercise and weight management can work together. The IDEA trial followed 454 adults with painful knee arthritis for 18 months. They were designed to exercise alone, diet-induced weight loss alone, or diet plus exercise. Knee joint loading decreased in all three groups. Numerically, the diet-only group showed the largest reduction in knee compressive forces, and in the adjusted comparison, diet alone performed better than exercise alone for this outcome. However, when pain and physical function were considered, diet plus exercise group achieved the best overall clinical results. It had less pain than both exercise only and diet only groups, and better function than both groups. Both weight loss groups also lost more weight than exercise only groups and showed greater reduction in the inflammatory markers IL-6. So the practical message is not lose weight first and exercise later. The practical message is for suitable patients, medically appropriate weight management may reduce demand on the knee, while exercise helps build strength and physical capacity. Does pain mean damage? Pain is important, but pain is not a live camera showing cartilage destruction. Pain may be influenced by joint irritation, swelling, bone marrow lesions, synovitis, muscle fatigue, weakness, poor sleep, stress, fear, and pain sensitization. The Lancet review explains the X-ray findings and pain are only moderately associated. Some people have severe-looking exercises with manageable symptoms, while others have substantial pain despite more modest imaging changes. A practical guide is this. Green light, mild tolerable discomfort, no major change in walking or exercise techniques, and symptoms settles reasonably. Continue and monitor. Yellow light, pain rises noticeably, swelling increases and the person starts limping or symptoms remain elevated longer than usual. Reduce the load, range, duration or resistance. Red light, seek medical assessment for hot and markedly swollen joint, fever or acute inability to bear weight, significant trauma, true locking, major instability, severe remitting pain or progressive calf swelling. The message is not exercise through everything. Message is exercise intelligently and adjust the dose according to the response. The one change rule. When progressing exercise, change only one major variable at a time. Increase duration, resistance, frequency, range or impact, but do not increase everything together. Suppose you currently walk for 10 minutes. Next week, do not increase to 30 minutes. Add stats, begin squats or start gently jogging. That is not progression, that is ambush. A few days later, their neighbor Meenakshi heard Doraisamy describing his new program. She came closer and said, "Doctor, I told him to increase slowly." Kamala immediately added, "He increased walking, stairs and squats in the same week." Doraisamy looked confused and defended himself. Doctor said progression and I progressed. I told him, that is not progression, Doraisamy, that is coordinated attack on your knee. Build gradually, observe the response, and then progress again. Final closing of this video. Your knee arthritis is real, your pain is real, but your X-ray does not automatically determine your future. Appropriately selected and gradually progressed exercise is one of the most important treatment for knee osteoarthritis. It is not the only treatment. Some patients may also require medication, physiotherapy, weight management support, injections, or surgery. But movement should not be abandoned simply because an X-ray shows arthritis. Find what your knee can tolerate today and gradually build what it can tolerate tomorrow. The goal is not zero load, the goal is the right load. In disclaimer, this video is for general education only and does not replace individual medical assessment. Exercise may need modification in people with acute injury, severe swelling, marked deformity, instability, inflammatory disease, or advanced symptoms. Please consult your doctor or physiotherapist before beginning or substantially changing an exercise program. See you in the next video, friends. Until then, goodbye.